I am the medical director of San Francisco General Inpatient Forensic Psychiatry Unit. This session is the first of a three-part webinar series focused on understanding and dismantling harmful behaviors and patterns in healthcare that disproportionately affect health outcomes for patients from vulnerable communities. Tonight, our first session on understanding and dismantling implicit bias in patient care. This session will be led by Dr. Danielle Harston. Dr. Harston attended Rutgers University for her undergraduate degree and earned a degree in biological sciences. She earned her medical degree at Howard University College of Medicine. Since 2016, Dr. Harston has chaired the Black Psychiatrists of America Scientific Program. She was recently elected as the American Psychiatric Association Black Caucus President. Dr. Harston has spoken nationally and internationally about the impact of racial trauma and culture on mental health. She is a contributing contributing author to the recently published book, Racism and Psychiatry, Contemporary Issues and Interventions. Her interests include consultation liaison psychiatry, resident education, minority mental health, cultural psychiatry, HIV psychiatry, and collaborative care. So without further ado, I'd like to pass this off to Dr. Harston. But before we do, just a few little reminders. If you have questions, please type your questions in the Q&A box. And if you'd like to speak, you can click on the raise hand button and we will unmute for you. We have provided a copy of the presentation slides for you to download into the chat box. We're hoping and know that this will be a wonderful session. And Dr. Harston, I turn this over to you.
Well, thank you, Dr. Peters. I appreciate that intro from my fellow Howard University College of Medicine alum, HU, here in the house. So thank you for that introduction. And thank you to the Santa Clara County Medical Association and team behind the scenes here who invited me to have this very important, pivotal, and vital discussion. I'm going to share some slides now. I think you all have access. I've made a few edits, but it should be similar to what you already have. So again, my name is Danielle Hairston, and for CME disclosure purposes, I have no disclosures, financial disclosures at this time. My affiliation, Howard University, is the institution that pays me, and that is where I am the residency program director. So we have some goals that I hope to achieve by the end of this talk. I'm a very interactive teacher and presenter, so this is going to be a little bit different. You all aren't able to talk to me, but you can write your questions in the chat, and also we will have a Q&A session. So we are going to define systemic racism. We're also going to define implicit bias. We're going to recognize and note some ways to reduce and eliminate your own bias when delivering healthcare to people and patients from communities of color. We're going to deconstruct social determinants of health and really learn specific techniques to help your patients to screen for trauma, to assess for racial challenges and biases in your patient interactions. So I'm going to say this early on, that I've written a lot about and spoken a lot about biases, but I am going to really delve into some systemic racism, because we have to understand that while bias is a palatable term that people are more willing to accept, biases are really informed by systemic racism and a culture that allows these ideas and beliefs to be perpetuated. So all racism is not overt. I think frequently I have comments and people will write to me or say to me, you know, I'm not racist. I don't use the N-word. I'm not part of the KKK. I never owned slaves. My family wasn't involved in that. I don't use racial slurs. I was never involved in a lynching. I don't believe in that. And those are all the overt examples and manifestations of racism. However, all racism is not overt. And we're really going to delve into the different ways that we can see racism systemically as we move through this presentation. So interchangeably, you might hear systemic, institutional, or structural. And it really is about the policies, the culture that perpetuate racism. I'm not really going to go into and delve too much into interpersonal racism, but know that interpersonal racism is what you see when there is hate exchange on a personal level between two individuals. And then internalized or internal racism is when someone has been exposed to and a victim of racism for so long that they start to internalize these beliefs and also start to believe and consider that, well, maybe all people from this group are like this. Maybe all Black women are angry because that's the system that I have been socialized in. So I wanted to make sure that we have an understanding of that. Many of you might have seen, I don't know if you've ever seen the iceberg descriptions. So there's an iceberg description of racism that Kamal Bell used in his CNN program, United Shades of America. And you will see that we see the overt examples of racism, as I explained, like just racial slurs, police brutality, race-based killings, things like that. But what you see below the surface that are more covert and things that are accepted in a society are things that really are informed by systemic racism. So systemic racism is sometimes called structural racism, sometimes called institutional racism. It's a system in which policies, institutional practices, and cultural representations and other norms work in various ways, often reinforcing ways to perpetuate racial group inequity. So the inequity is what's very important here because of the power dynamic. So I've heard people say that, well, are Black people racist? Black people can be racist, and really it's important to note that racism is about the power dynamic. And systemic racism identifies dimensions of our history and culture that have allowed privileges, that's again with the power, associated with whiteness and disadvantages associated with color to endure and adapt over time. And this is from the Aspen Institute. I really encourage many of you to look at their website. They do an excellent job of defining systemic racism, biases, and other definitions. They have like 11 key terms that you should know, so you can Google that easily from the Aspen Institute. So we got that. All racism is not overt. But let me make sure we really understand this. So racism is explicit hate, yes, but that's just one manifestation. I'm going to give you some examples of other things that are racism and that fall under the umbrella of systemic and structural racism. One of them is denying that racism exists. When you ask an oppressed people, are you sure that that was racist? Or you say, I don't think that's racist, when a patient or a colleague explains to you that they experienced racism in a certain way. This is called gaslighting. Another example of systemic racism, or something that is more covert and socially acceptable, is denying home loans to Black people from certain neighborhoods or living in certain neighborhoods, limiting potential for economic wealth. And this is called redlining. And I'm going to go a little bit deeper into this so we can really understand how this impacts healthcare and impacts the service that we provide to our patients. Another example is weaponizing privilege. So calling the police to report Black people for living their lives. This includes for eating, sleeping, sitting, jogging, bird watching. These are all examples of covert racism. We also see things like sentencing disparities in the criminal, I don't use the term criminal justice, but in the legal or the carceral system. So this is where we see a sentencing difference between offenses for crack and powdered cocaine. That is an example of systemic racism. We also see refusing to hire and promote employees. So in employment, using coded language like they weren't the right fit, or they make statements like, I don't think that this is the right place for you, with no real reasons behind this, no concrete explanations. Also, for us, it's important to realize that providing biased healthcare, so treating BIPOC patients and white patients differently, even though they present with the same symptoms and concerns. Bias, as I said, is really informed by racism and the culture that you're socialized in. So a bias is a preference. It may be favorable or unfavorable. Now, explicit bias, now this is something that people are able to grasp and really can digest more easily. So an explicit racial bias is conscious. A clinician or a physician acknowledges that they have this particular preference or aversion for a certain racial group, and it can be suppressed or acted upon due to societal norms, due to the culture of the place where you work or interact or live. Now, this can lead to racist acts that are purposeful. So these examples are things like a physician who refuses to provide care to Black patients, a physician who joins an anti-immigration rally protesting, providing clinical care to Latinx immigrants. Now, things like those are explicit. They're almost tangible that you can take a note of. Implicit racial bias. Now, this one is not as simple and easily understood. So this is unconscious associations of stereotypical attributes with a particular racial group. So similar to explicit bias, it can manifest as a preference or a negative association. You usually see this during stressful times, more fast-paced, high emotional tone situations, and it can lead to the expression of behaviors consistent with an implicit bias. And I want us to really be careful here, and I'm very careful with the definitions, because while some biases are implicit, that doesn't mean that you are not complicit in perpetuating them. So some examples here for you, and these are examples that are mentioned in the book that Dr. Peters mentioned. I am a psychiatrist, so I use frequently examples from psychiatry. I try to mix in some others here, but in the book that myself and several colleagues have written, Racism in Psychiatry, really discusses issues like this. So this is a psychiatry case. A physician whose neighbor was robbed by an African-American male one day prior is currently working in an active inpatient psychiatry unit. The physician is not aware of any bias that they may have, although they are exposed frequently to things like the nightly news, where African-American males are often profiled as aggressive or violent or incarcerating. So during a shift, an acutely agitated African-American male patient is having a crisis. The patient was initially posturing and threatening, but becomes calm after staff approach and de-escalation. The physician, feeling threatened and recognizing these cultural norms and systemic policies and beliefs that have been passed down, insists that the patient be restrained to manage potential aggression and is started on a high-dose antipsychotic, despite patient's calm state and the lack of consensus among staff. So that's just an example of how implicit bias can, because of the exposure, because of the way that you're socialized, inform your clinical decision-making. Now, like I said, that was an example from psychiatry, but I know everyone here is not a psychiatrist, and we are talking to the Santa Clara County Medical Association, so I'm going to try to include some other examples that are cases that you should really be aware of. So there is the case and the evidence-based reports from Schulman et al. So Schulman and colleagues from 1999. If you are not aware of this, this is something that you should look up. This is a cardiology case where there were biases observed in the treatment of MI. So they simply had patients present with the same exact, no change, no difference presentations, which would be worked up which should be worked up for MI. They only changed the race and gender of patients. And when they were given the exact same scenarios, exact same clinical presentations, they found that African Americans and especially Black women were less likely to receive referral for cardiac catheterization. And the only thing that was different here was the gender and race of the patients. There's also the more recent Hoffman and colleagues paper that coming out of UVA that identified differences in pain ratings. So in this study, medical students stated that they felt Black patients had thicker skin and did not experience pain the same as non-Black patients, as white patients. We also have another example here from Strakowski and colleagues from 2003, where we see something frequently that happens is the overdiagnosis of schizophrenia in Black and African American patients. And in this case, patients' presentations were given. They had the same symptoms. They only differed again by race. And overwhelmingly, you saw that Black patients were diagnosed with schizophrenia instead of rating and assessing their mood symptoms, and the white patients were more likely to be diagnosed with a mood disorder, with the same symptoms. So these are things that we have to really understand, that these are biases. I took it back to 1999, brought you to some in 2016 as well. If you think this is something that does not happen now, it continues to happen. So I really want to emphasize something, and you're going to see me coming back to this point again, that individuals are a part of a system. So we are trained to care for individual patients, but physicians should understand how systemic racism affects their patients. So if you remember, one of the goals that I had here was to deconstruct social determinants of health. And I really feel that social determinants of health is a more palatable, a more acceptable term, but really social determinants of health are determined by and informed by racism and structural racism at that. So I really want to emphasize the point that we have considered race as a social determinant of health, but it's really and truly racism, the social construct of race is not at fault. We're talking about racism, which is how we discussed earlier, the discrimination against people and the power dynamic. Now, we've seen these disparities. The one that we're most now aware of, if there is any silver lining to the COVID-19 pandemic, it is truly the highlighting of racial disparities in patients who have suffered with the COVID-19 virus. We've seen a higher incidence and higher prevalence in Black and Brown communities. Other places we see disparities are in the lack of providers from diverse racial and ethnic backgrounds. That's something that we know. We know that fewer than 5% of physicians are Black or African American in this country, and there's that disparity between the population of this country and what we see, and that has various reasons that again go back to systems and privilege and who is exposed to the medical profession, who's exposed to medical education, and who has the privilege to even apply for medical school. Now, I'm going to go into this a little bit more because I feel like this is an example that people can truly understand about housing, food security, employment, transportation. Like those are all connected and a part of a system. And I'm really going to encourage all of you to understand this when you're making treatments, when you're making judgments, when you're making clinical decisions for your patients. You must also know that there is a mistrust of the healthcare system in many BIPOC communities, and that is because of history. We also have underinsurance, and of course there is stigma, both when we think about seeking care period, and especially when we think about mental health care. Again, remember, I'm a psychiatrist. So this is a map that I found for, we're here in California. well, you all are, I'm in DC. I found an example for San Jose and Santa Clara and its vicinity. So I'm really going to try to explain to you a system of racism and discrimination that was purposely made to discriminate against a certain population. So I'm not a historian, I'm not a history professor, but it's something that I enjoy. So we're gonna take a little history lesson here, a brief story. So in the 1930s, a federal agency called the Homeowners Loan Corporation, HOLC for short and abbreviated, created residential security maps of major American cities. So that's what you see here for your area. And red areas were deemed hazardous, and there was a systemic denial of loans of home ownership in these areas. So with redlining, we saw a federal agency, a system, a policy that encouraged predatory lending and created these insular neighborhoods that some people might refer to as ghettos. Now, I'm gonna switch that because it might be distracting. Now, we have these predatory lending practices, we have these insular neighborhoods, and then we also have a US government and Supreme Court that says that education can be funded not at the federal level, but at the local level. And this is informed and this is decided upon from taxes, which are determined by housing. But you have an area where people are not allowed to participate in the biggest opportunity for wealth building in this country, which is home ownership. So taxes and education taxes are informed by education, and that's determined by housing. Housing also determines where hospitals are. So you might have a medical desert and you might have a food desert. Then you might not have transportation and you might not be able to leave your insular or ghetto neighborhood. And you find that people are trapped within a certain system and they don't necessarily have the opportunity to leave. And even if they do have the opportunity to leave, that you have to remember that this is where their social networks are. So we have to remember, and it's important to understand that we are not without history. We are not a people or a nation that does not have a history. It's important to understand the experiences, risks, and trauma of your patients, especially when you're making decisions about their healthcare, when you're thinking about whether or not they can come to your appointments, when we're calling patients non-compliant, when we are prescribing medications that need to be picked up, that have high copays, whether or not they're able to afford these, whether or not they have the transportation, and whether or not they are informed enough or you have educated them to the point that they understand what is going on with their treatment. So clinicians who focus on treating solely the presenting symptoms without giving consideration to the socio-political and historical context are destined to be inadequate. Generational trauma in BIPOC communities, you sometimes might hear it called intergenerational trauma. It's suffered from one generation to the next. So be this individual or be this collective. And this is something that we see passed on by future generations. Again, the COVID-19 pandemic has highlighted this. Intergenerational trauma is defined as a transmission of historical oppression and its negative consequences across generations. So when you're wondering why a patient doesn't trust you, think about how that patient's family, their grandparent or their parent might have been a witness to or known someone who was associated with medical oppression, medical mistreatment with something like the Tuskegee experiment. Now, people like to highlight the Tuskegee experiment, but this is something that we see across the nation. This is something that we have seen across specialties. So again, I said that I was going to come back to this, right? That individuals are a part of a system. Now, frequently, systemic problems are framed as individual problems, and that's where we find errors, and that's where we have challenges with treating our patients. So really the way to, one, combat these disparities on your individual level, I'm gonna say, is instead of thinking about compliance, think about understanding the social determinants of health or systemic racism that are at play here. Think about what it takes for your patients to be able to come to see you. Think about the digital divide that they are experiencing during this COVID-19 pandemic, whether or not they have to decide if they can take time for a phone call with you, if they have minutes or if they have data for that, or if they just have to decide whether or not they spend their money on that or rent or food. And think about how policies and institutional practices and the culture have led them to this place. So really consider interdisciplinary treatment planning, consider community engagement, consider looking into programs, asking your social workers who work with you, asking and learning about the communities in which you treat patients that you don't just come into, that understand that people actually live here and understand the dynamics of that community, and work towards collaborative treatment goals. Now, a collaborative treatment goal might be that you engage in asking your patients, have you been a victim of racism? Has this affected you? And has it affected your home life? How has COVID impacted you? It's not just checking off boxes on your H&P. Patients are suffering, and this is something that we have to consider. And it's unfortunate that this pandemic had to lead us to this time and this place and this period, but this opportunity is one that we must take advantage of. So really understand that when you're thinking about how to treat your patients, and when you're thinking about, oh, this patient is non-compliant, or this patient is not adherent to the plan that I have made, they not accepting of it. Think about all the systemic factors that are at play. Another thing that you can do, I see this frequently in psychiatry. Also, we see this in family medicine and also peds. We ask patients about their history of abuse. We ask patients about infidelity. We ask patients about their sexual history, and those are things that you can ask about. However, when it comes to race and it comes to racism, you are uncomfortable. Well, you have to be comfortable with being uncomfortable. These are things that your patients are enduring. These are things that your patients have been enduring for longer than you may be aware of. And you need to ask them, you need to address them. And also, it's in the way that you communicate that. Now, if you happen to not be a person of color, not part of the BIPOC community, not a Black or brown physician, come with that understanding and present that first and say that, I don't understand what it's like to be in this situation, but let me know if this is something that's going on so we can work together, collaborate to find a treatment and to find a plan that works for you. I've seen before, I've seen out on social media, and I've heard some physicians say and things on listservs that hear a racist joke, you should say something. And that's the way that we can start combating biases in medical education and in medicine, that when you hear this, you can say something. That is the first step. That is a way that you can be an ally. And I am going to have to say and encourage you to understand that we are beyond that. We are at the point of when you see a racist policy or practice, you say something. And actually, let me take it back. No, you don't say something, you actually do something. So when you see something at play, when you see something that is unjust, when you see something that is not fair, this is the time that you actually do something to advocate for, whether it's your patient, your colleague, yourself, because remember I talked about internalized racism, your patient, your colleague, yourself, your medical student, your trainee. This is a time where you have to be on, I'm an ally here by posting a Black Lives Matter post, by posting a Black square. We are beyond that. Now you need to leverage your privilege and you need to advocate for your patients. There are allies, there are sponsors, and there are advocates. Someone can be all three or someone can just be one. But whatever it is, please beware of performative allyship. It's not just about saying, I believe in Black Lives Matter. It's not about a statement in solidarity. This is about a culture shift. This is about sponsoring. This is about advocating. And by sponsoring and advocating, literally in sponsoring, I mean putting your funds, your time, your energy, and your privilege, that power dynamic behind the patients, the people, your colleagues, your trainees, your students who need this. So one of our goals, if you remember back 30 minutes ago, one of our goals, I feel like I'm Mr. Rogers. Neighbors, you're still there? Okay. One of our goals was how to reduce and eliminate your own biases. You have to get uncomfortable. You have to get uncomfortable. You have to acknowledge that racism exists. You have to acknowledge this is going on. Frequently, if we go back to the slide where I said that asking someone, are you sure that was racist? Or stating that, I don't think that was racist, that is centering you and your needs. And that is not doing what our first step of being intentional about addressing biases and systemic racism in medicine is, which is validating. So you have to ask uncomfortable questions. You need to ask yourself, is this the same way that I would treat a white patient? Go back to the standards of care. Recognize that you have these biases and check yourself, and also check others. Remember, I said that we are beyond the, if someone says a racist joke, say something. Now, this is going to be challenging depending on what year you are. If you're a medical student, if you're a resident, it's difficult. So just ask why. Like, oh, why are we doing this instead of this? And really have that person have to explain to you why they are taking this step, or why they are ignoring this treatment or not offering the same treatment opportunities that they are offering to a white or non-BIPOC patient. So we have to get uncomfortable. We have to ask these tough questions, and we have to go back to the standards of care, evidence-based medicine. That's what we have to do. Why are you not offering this patient a cardiac cath? Why are you not offering this patient buprenorphine? These are things that we've seen. And you have to ask yourself, is this the same way that I would treat this patient, this BIPOC patient, if they were a white man or white woman? Am I giving them the same respect as a patient? Am I giving them the same amount of time that I would give someone else? Am I listening to their concerns in the same way? So we can talk about it. I tried to keep it short so that we have plenty of time for the discussion. I am welcoming of all your questions and comments. If you don't get to ask me these things, know that you can still find me, DanielleHairstonMD.com. That's my website. Also, At a Doc Named Danny is how you can find me on the socials, Instagram and Twitter. And also, I frequently every month host a Black mental health public-facing town hall at Black Psychiatry on YouTube. So you can find me there as well. So I am now going to open it up for questions, for Q&A, for discussion. I see that I already have some comments here. I think that Dr. Peters is going to help us to moderate this. And I am here for the engagement and for the questions, challenges, whatever it is, we are here to discuss for your complete CME credits.
Thank you so much, Dr. Harsin. That was very powerful and very insightful. And I know that the participants probably have had a lot to think about. I know that you talked earlier that you really would like to engage more in a dialogue with questions. You know, a lot of times in the presentations, they just want you, give me the, just the facts, just the questions. But I think you were more interested, which is why we have allowed it more time for people to engage. So if there's anyone who would like to start or have a question or a comment, often comments are not encouraged, but this we encourage comments because we'd like people to be able to have an opportunity to talk about some of these issues. One of the things I was asking people and wondering is now that people have had an opportunity to think about it, are they aware of any examples in their experience where they have observed bias in patient care? Because as you say, some of the things are not conscious, some of the things are unconscious, and it may be later. People may say, wow, why didn't we offer a calf to that person? And it may have seemed like a good thing at the time, but now that people have had an opportunity to think about it, we would encourage your comments. So I do have one question right now from Karen Glover, and wants to know, is there a curriculum for anti-racism for residents?
Well, Corinne Glover, hello, shout out to Corinne Glover, one of my psychiatry colleagues and friends out there. So there are a couple anti-racism curriculums out there. So one, if you happen to be an APA member, we have a racism CME that's there. And luckily we have the Santa Clara County Medical Association who is having this series that will be there, as well as I think that if you go onto MedEd portal, you will see one from my colleague and good friend Morgan Medlock, who has a systemic and structural racism curriculum that's there. I believe Yale also has one. I think that UCLA has one as well. So they are there. And if you check the MedEd portal, I'm very sure I've seen it myself and we've used it as well. So you can find that from Morgan Medlock as a great option. Also, if you go on the APA Structural Racism Task Force page, which is free to anyone, you can also find resources there. So that's what's there. Dr. Glover, thanks for that question.
Okay, there are two new questions, and actually I was going to call on them because they were two people who had their hands raised. So I'm going to call on Robert Goldberg. Robert Goldberg's question was, please talk about implicit and subconscious bias as it relates to medical care.
Okay, so do you have any further thing to ask there, Robert Goldberg, or should I go ahead? I see that you're here and able to comment verbally.
Well, let me flesh it out just a little bit more, but number one, thank you for fabulous presentation and giving us your time tonight. So in addition to the question, so I've been taking, another course on stereotyping and implicit bias or unconscious bias, and just the stereotypes that we have deep inside of us that just make us prefer some things over others. And they may be, and in this context, they're racially oriented, but they could be about, what color cars I like, as opposed to what color food I like. But in this case, it could be what I've been brought up with to just expect either from Black people or Asian people or any people of color that I'm not even in touch with. And so how do we, as physicians, one, get in touch with it, and number two, guard against that bias as we're interacting on a daily basis with patients, staff, residents, whomever?
Okay, I understand your question further now. Thank you for that explanation, Dr. Goldberg. So I think that you can do as many trainings, cultural competency trainings as the day is long. However, it's really about you taking the time to address this yourself. I know that there's the IAT to test for implicit biases, but we have to recognize that most of us have these implicit biases because of how we were raised and how we were socialized because of this system that we're in. So you might see, it might be a preferential bias. It might be that you think that there's the model minority and that, for example, Asian patients are always listen and they are compliant. So you might not think that you have to explain things to them as thoroughly, or you might think that a Black or Latinx patient is not going to do what I say anyway, because that's the culture, or that's how you've been trained and educated. So you might not offer them the same treatment options or the same medications or the same follow-up plan that you would offer someone who's not. So how do we really address this? We address this by asking ourselves these tough questions. Ask yourself, is this the treatment that I would give to someone no matter what? Ask yourself, is this the way that I would evaluate a medical student or resident no matter what? Go back to your standards. Really ask yourself, you have to be uncomfortable, but this is where we are. I mean, it makes you uncomfortable, but this is where we are. You have to be comfortable with asking yourself these questions and asking others around you who perpetuate these biases, whether or not that's what's going on here. Ask yourself this and be honest with yourself and really reconcile that within yourself. That's your job that you have to do with yourself, and ask yourself, am I doing what I would do for any patient? Is this what I would do? And I can use an example. Now I work in DC, but previously I had the pleasure of working in a city that I love, Baltimore, and really there's a lot of substance use in Baltimore, and you would see the treatment of patients differently when they came in for pain medication, because of really what we would notice is the color of their skin. And ask yourself, would I be giving this patient, or would I be refusing this treatment or this pain treatment or this anxiety treatment to someone if they were not a person of color? So that's my answer for that question.
And this is Dr. Peters. I would like to make a comment into that. Those are all great questions that before I was in forensics, I was in cross-cultural psychiatry. And one of the things is the further the patient is from your own experience or comfort, the more time you may need to take. Because I know it's very difficult because we're forced now to work usually very rapidly and without taking an opportunity, enough time with patients. But the further the patient's culture is from yours, understand you may need more time you need to slow down because it's going to be when you're moving rapidly that you're more likely to go to automatic presumptions and unconscious things. So that was just in a comment. Well, we have a lot of other questions coming up. So the next one, Argavon Sauls, and raise your hand.
Yeah, I can ask it if you want.
Yes, okay.
Yeah. Well, first of all, thanks so much for this talk, and I'm sure that everyone enjoyed it as much as I did. We appreciate your time out here in Santa Clara. I have a question. You and I both spend a fair amount of time on social media, and I see a lot of things going around, to your point about performative allyship, that make me a little bit concerned, and I'm wondering how we can convert these people who I think have good intentions into becoming doers. So for example, back in June, you may remember this, there was a series of posts where people were saying, I pledged to stand up against racism, and they were tagging like 20 people. And then that next person was taking the same pledge, and I'm sure that it was very well intentioned, but what I don't know is what any of these people was doing, like actually in life, to make a difference. Any thoughts you have about how we can convert people from at least starting to say, yes, I believe this is wrong, which is a good first step, to like the next step of doing something meaningful?
Thank you for that question, and shout out to Argavon, whom I share the mic, colleague over here on Twitter, friend and fam. So I would have to say that this is again where we have to be very wary and aware of performative allyship. But the group that you're talking about is the group where I see the most promise. Like, this is the group that says, I realize this isn't right. I realize something needs to change. So there's room for improvement. There's room for success and growth. I find in this group as a you know, as compared to someone who is like structural racism doesn't exist and I'm not talking about this, I'm not racist. So this is a group where I find that we can really have advocates and allies and sponsors, but how do we move from a post? I think that physicians are very educated, very knowledgeable, and can research anything that there is, but they really have to move away from this is just a post to what are you doing? And I don't know if we are supposed to be policing and asking people what are they doing, but I think that organizations and systems need to ask and show what they're actually going to do here. And Dr. Argavon, I don't know if you feel comfortable saying, you have a lot of followers, you might say like, what are we doing? Post like what are we actually doing? What are we doing? We saw the tags, we saw the black squares, we saw the Black Lives Matter, we saw the I stand with you, but just a follow-up check-in, what are we doing? Have you educated yourself? Have you taken steps? Have you taken a time to step back and look at yourself and look at the place where you work, for those of us who are in leadership, to really address these issues and not just write these solidarity statements? So I think that I'm concerned about those as well. I'm concerned about those performative ally or seemingly performative actions, but we have to really ask, oh, what are you doing? Like, oh, did you donate to something? Did you invest? Did you ask BIPOC student or resident to work on something? Did you have them, include them in your research? I think we have to be very direct. Again, we have to make people uncomfortable.
Okay, thank you. We have a lot of questions there, but I would like for a moment to go to the chat room and maybe people who are able to look, because there are some members who have been suggesting other books and other things. So there's Wendy Kahatsu. We all need to dissect the faulty evidence that promotes race-based standards in medicine, i.e. GFR and pulmonary function tests to start. Another question about how can people change the culture in a department or in a medical school. This was Amit Pandya. How can I change the culture in a department, a medical school or clinic with lack of diversity, accept more Black and Latino trainees and physicians? What if the leaders are not on board with holistic reviews and lack of knowledge about minority communities? And again, other questions about recommending, what would you recommend that all physicians should be trained to recognize and address implicit bias, as we talked about? One of the Wendy suggested the Institute for Healing and Justice in Medicine also has resources for medical students, residents, and docs in practice.
Okay, so I think I'll try to, because I saw a couple questions about this.
Yeah.
Maybe I will be able to answer the question about how can I change the culture in a department, in a medical school or clinic with a lack of diversity to accept more Black and Latino trainees and physicians. So I don't think that this is something that necessarily you have to accept for yourself, because there's also a lot that you have to take on the responsibility for yourself. But I think that it starts just by asking a question, like, why? Why do we not have any other Black or Latino physicians and trainees here? And the answer can't be, oh, well, no one wants to be the only one. So that is one that I do not accept, and that's a place where I think that you can give some pushback. It's not acceptable to say, well, no one wants to be the only one. Well, they shouldn't be the only one. So what are you going to do to sponsor and work on retention here so that you can, when you interview applicants for residency or for faculty positions, you say, we recognize the lack of diversity here and we are working on it, and we will support you by doing this, this, and this. This is a way that we will do this. We will give you time for this. We will give you time for this. We will provide you with a sponsor. We will advocate for you. You will have a mentor. You will have this protected time. This is a way that you can take steps to actually move beyond making statements and actually getting it done. So your question is, how can I? So if you are in leadership, that's how you can. If you're not in leadership, ask the questions. And you can ask it in a, I saw another question here, you can ask it in a tactful, non-patronizing way. You can ask just like, what are we doing? Or what's going to be done here? I just have a question. Why don't we have any other doctors like this? What are we doing to change this? Or you can say, I've seen some excellent medical student applicants who are from the Black and Brown BIPOC communities. We need to look at them. What are we doing? Ask the questions, because that makes them have to come up with an answer. And as I tell my residents, document, document, document. So ask these questions via email so you have what we like to call receipts. Okay. What were the other ones? Oh, there was another question about, I don't know, Dr. Peters, so many questions.
Yeah, there's a lot. People have a lot of questions. I was trying to see, there were some other questions regarding training and other physicians. Maybe before we skip to a different area, maybe a related subject, Prasanna Menon said, she's an OBGYN of color and has observed implicit bias amongst a few nurses. How do we talk to them about it without it becoming confrontational? And can ACOG create a team of MDs such as yourself who may show them ways to recognize and hopefully change their bias? So this is a little bit different in terms of for talking about some of our other members on our team who have other disciplines who are different training objectives, and how do you interface with that? So.
Okay, I think that's a great question. Well, two-part question. You have observed implicit bias and amongst a few of the nurses. So I think this is a time where, again, you can ask the question or you can point it out, but just point it out in a casual way, because people do. People don't want to hear that something that they might be doing is racist or biased. People have problems with that, but as I've said multiple times, we have to really get uncomfortable. So when you see something, if you have a subtle way of saying, we should have done such and such for this patient because that's the same thing we did for this other patient. Or why didn't patient X receive the same thing as patient Z? So just do some comparison there just to point it out. Just say, next time we need to make sure that this patient gets this as well. It's an opportunity to really attack the biases that people have and put it to the forefront of their mind so that they're not able to just glaze over it. And if no one says anything, then again, that perpetuates a norm and a culture that this is okay. And that's how biases are informed again and reinforced. So that's an opportunity. Can ACOG create a team of MDs? I think that there are OBGYNs like myself. I've seen some posting on Twitter, and also I know that Howard University trains our residents and students to know this as well. I think that there is, I can't remember exactly what it is, but there is a Black women in OBGYN or something like that on Twitter. And I know that they have, so there are groups popping up all over social media and Instagram and Twitter who are involved in this type of work. So yes, ACOG also needs to get on board with this. Okay,
thank you. Kind of going to a slightly different area. Tracy Phillips asks, can you comment on the psychological stress and impact of bias and racism that the Black-brown physicians endure as healthcare providers?
Yes, I definitely can. So this is something that I frequently speak about and have to bring up to people, because I think that in the field of medicine, that people don't even really understand the privilege that they have with their colleagues. So I will always say that before a physician, before anything else, I am Black. So I am a Black physician, I am a Black psychiatrist, so that we remind people that I am part of this community. I am a part of this community that is suffering. I'm a part of this community that is experiencing this collective trauma, this vicarious assault every day, that I have to see someone who looks like me, someone who looks like my family members experience this race-based violence and killings. So I think you have to really say, hello, like, this has affected me. Like, be direct and say, you know, I'm struggling here. I'm struggling with this, like, or that has upset me, or I have children, or I wonder and worry about my sons and daughters, spouses, partners who go out, and I worry about them. You have to say these things to remind people that this is distressing psychologically to me. Viewing these things, we have seen studies that have said that, in psychiatry, we have seen studies that have said that experiencing, and peds as well, experiencing, witnessing like trauma and violence against people from your community and the communities that you identify with causes psychological damage the same, and you can see similar symptoms that you do with patients who present with post-traumatic stress disorder. So we have to really understand and recognize that we are a part of this community, we are suffering, and at the same time, we're trying to provide the best care that we can to patients who look like us and also don't look like us. And we identify the same way as other people in our community. And you have to say that to people. And I say that to people because it seems like they forget, like they don't know that medical students, residents, physicians who have family members who are experiencing this pandemic are more likely than their non-BIPOC colleagues to have patients, who have family members who are patients with COVID. These are things that we have to say and drop these reminders so that people can, again, validate the experiences. That's my answer. Hopefully that was a complete.
All right. I don't know if that was a sufficient. If Tracy Phillips is still online, did that answer your question? And I'm just now getting, Amy Portmore says, you can ask for example ways to ask Black patients about their history of trauma, actual works or phrases. I don't want them to feel I'm being racist and asking them if they have had trauma. They think I only ask Blacks about this. And I've actually seen some other questions that are variations on the topic, really about how to more carefully be able to question and, to answer people, for people to answer questions about maybe very painful areas. Let's see, who else asked that?
Okay, yeah, I saw that somewhere else as well.
Yeah, and I saw it too. Alicia Toussaint, when asking about past trauma, history of incarceration, would be very important to understand part of barriers of adequate housing. This is becoming even more prevalent, especially people of color. So again, I think people, even in trying to recognize, also want more guidance on how to ask questions in their best way.
Okay, so I think that I understand and completely appreciate that this is challenging and would put you in an uncomfortable setting. But first of all, they might think you only ask Black patients about this, but there's nothing wrong with that. Like, there's nothing wrong with asking Black patients about this. It's really your approach. I think, one, to have some humility. So I don't subscribe to cultural competence exactly, but cultural humility and appreciation and affirmation. So say, I understand and recognize that I am not Black, I'm not Latinx, I'm not part of the BIPOC community. However, I just really want to check in with you. So come with humility, come as your humble self who actually is showing compassion and showing empathy, and say that I recognize that this is something that's going on, as sincere as possible. And I just want to know, is this something that you've experienced? Is this something that's going on in your family? Is this something that you want to talk about? If you don't want to talk about it, I completely understand, but at least give them the opportunity to say, I don't want to talk to you about this, or yes, actually, I have been experiencing this, and I appreciate you asking me this, even though you're not part of my community. Just say it's really in your approach and how you ask the question. So come with the humility and say, I am coming from the best place possible. I'm just trying to figure out if this is something that I can help you with, that is affecting you, if you need more services. So approach it in that way. I think people respond best when you are your authentic self and you come with authenticity and you say, this is why I'm asking you this question. I'm not asking you this question because I want to report you to your PO or I want you to be incarcerated again. I'm just trying to understand, you as a complete person and how we can help you.
Okay. Moving to sort of another area, one of the participants, Kim Jones-Fearing, asks, I think, a two-part question. And if I don't get it correctly and getting it, please, could be able to answer yourself or ask yourself. Basically, she said, I see disparities in children and adolescents in Maryland being treated at OMHCs. There is a lack of referral options when autism, learning disorders, and intellectual deficiency is suspected. Do you see these disparities in Washington, D.C.? And then further, there was an explanation. I'm referring to the need for psychological testing and neuropsych testing for the purpose of diagnosis and managing treatment goals.
Okay. I think I'll try to answer that. So the most simple and basic answer I can say is yes. Yes, we see these disparities with Black and Latinx children. This is something that happens commonly. While I addressed earlier that the evidence of overdiagnosis of schizophrenia in particularly Black male patients, there's also the overdiagnosis of things like conduct disorder or attributing some certain behaviors to being bad children, and there's the opportunity is missed for them to be diagnosed with something like being traumatized or being a victim of trauma or having anxiety or depression or ASD as well, or intellectual disorder, that is missed, and they are instead diagnosed or misdiagnosed with a conduct disorder or a behavioral issue. So we do see these disparities. Yes, we see them in Washington, D.C. Yes, we see them in Maryland. We see them nationwide because, again, these are the biases that we see continuously perpetuated in medicine. So that was my answer to the first part, and I'm trying to get to the second part about referring to the need for psychological testing. So again, yes. Yes, my answer is yes, we do see these disparities, and these are things that are, again, informed and perpetuated by systemic racism and biases. So how do we attack these? The same way that I've said, pushing to advocate for your patients. Like, I want my patient to receive the same treatment, to have the same opportunities as these other patients, simply asking why this was not done.
Yeah, thank you. I also would like to make a comment. Historically, psych testing, neuropsych testing, the norms that are determined are based on different populations that have been studied in their presentations. And one of the difficulties, particularly for not just the African-American community, also other cultural communities, whether they are Latino, or they may be from, East Asian cultures, that the norms for those behavior and presentations and how that translates to a diagnosis have been determined. So the further the patient that you are testing is from the norms of those basic control groups that were used to design that test, the less accurate some of those diagnoses are going to be.
Yes, with the norm being someone who is not from a Black or brown community. Correct. Okay.
Okay. Just had another question. The Gladsteins, would it be okay to have a local medical society committee formed to review and recommend discussions with a physician who was felt to be inappropriate since there's no local setup for most, and it may be peer talks may move a change in a physician's conduct?
I
That's
think
kind of more complicated situation because I don't know how they would set up it sounds like a sort of an intervention or is it training?
particular individual. So I don't know if I can speak to that specifically, but I can say that it is okay and appropriate for local medical societies to form task forces or a force for your group that will address systemic racism and will address institutional racism and the racism in your organized medical group. And maybe out of that will come some ideas if a work group or subgroup has ideas for how to discuss these things with physicians and recommend discussions with the physician further. But I mean, I don't know exactly the situation that you're asking about the Gladsteins, but I would think that it's appropriate for medical societies to start a committee to really discuss the issues of racism that are existing in their society, in their organization, so that they can address these at multiple levels.
Okay, I'm gonna look a little bit into the chat room just to see if there's something, there's been a lot of different discussing amongst themselves, which is always good. Terry Hill had actually recommended to all the panelists and thanking that there been a focus on racism and housing as one of the historical roots of present poverty. For a justly celebrated history of discrimination in housing and jobs specific to San Francisco East Bay and resistance, I recommend American Babylon by Robert Self. So that's another book. I don't know that book, but I'm gonna look into it.
I also don't know that book, but I will also check it out. Another book that I think is helpful for understanding this is Why Are All the Black Kids Sitting Together in the Cafeteria, which, okay, I must have put it in my room. It's not on my bookshelf. So that's a good book to address this topic, a good place to start. Also, So You Want to Talk About Race is another good book that I would recommend. Color of Law is an excellent book as well. I agree. Thank you for that. So those are some that we could check out. And just to the question of not saying our patient or my patient, I guess it is in your perception. Patients might, I haven't had that comment before, but I'm not suggesting ownership, but our patient or my patient is someone that I care for and that I'm trying to be inclusive of. But I could see your point over there.
So I'm sorry, go ahead. Mm-hmm. I was going to, I see there's another one, Color of Law. We're getting closer to our time where we're gonna wrap up. And there was another question from Dr. Clifford Wang, and I'm gonna read it. And if it is not, if he needed to explain it some more, it would be great if you could unmute him. But he says, we are finally beginning to look at healthcare disparities due to racism. Do you have any advice as to how to best address measuring it and drilling down to the root causes?
Any other comment about that, Dr. Wang, before I answer?
No, thank you very much. I was just asking because, I mean, you mentioned that we've had our own biases implicit as well in, either overdiagnosing schizophrenia or other sort of conditions. And I wanted to make sure as we start to look at those things that we don't put those biases as well when we do the measurements and stuff. So, and then how do we then, as even as individual health systems look at this, we can look at it nationally, but how do we then start to address those issues within our system so we can take action to change that, because that's one of the things I think that's going to make a huge difference, for our patients. So I was just wondering if you had any advice around that. We're starting to look at that and locally. And I didn't know if anybody had any advice around that.
So I will say that I definitely encourage organizations, healthcare systems to approach a consultant, because when you're doing something from within, there is the chance to continue the biases.
Yeah.
There's a chance to just overlook things, to brush things under the rug, and again, not validate the situation. So I encourage, and this is something that I encourage for the organized medicine group that I'm in, that we really have an outside consultant come in to, one, if you have the ability to really go through and delve into the practices and the policies of your institution and of your system. And also, that's something that I think that should be invested in. I don't think that should be even a question. Like, this is the time, if you want to move beyond just these statements of solidarity and these allyship statements, is to actually investigate them and put the time, money, and effort behind it. So that would be my recommendation for that. If for some reason they say, which shouldn't even be acceptable, that we don't have the money for a consultant or something like that, then at least to have an outside speaker, not to rely on the people, like, unless they want to work on these DEI, diversity, equity, and inclusion committees, to actually have someone else come in. Sometimes it takes another voice to really bring these things to light for these organizations. No problem. Thank you for your question. Dr. Peters, I do see one question that I hope that I can answer from, if you see the one from Alpha Stewart, who is...
Yes, I was trying to get back to that. I thought we had answered it. So actually, I would hope if Dr. Stewart is still there, or if you have a better understanding of it, because I thought I thought you had answered it. So if she could clarify more, or if you have a better understanding, because I think we talked earlier about training, and I may have misunderstood more detail that she may have needed.
Dr. Stewart, one of my mentors and the first Black president of the APA, American Psychiatric Association. Can you clarify your question for us?
Well, certainly, Dr. Harrison, great job. And I did hear a response around training, and I'm thinking more specifically around academic medical centers have a responsibility for their faculty to also be part of the buy-in, whether that's voluntary or mandatory. And I just wondered if you had some recommendations that we should be putting in front of academic medical center directors, deans, chancellors, presidents, around how we make sure that now that you're giving the attendings and the trainees and the medical students all this great advice about ask the question, I don't want them to run into faculty who said that's not important and that's not what we're going to talk about. So if you could speak specifically to that perspective. Thank you.
Thank you. Thank you, Dr. Stewart. So definitely that is important, and thank you for reminding me of that. Now, this is a time where we have all these evaluations. You have an evaluation at different levels from the dean, from your chair. We have these different metrics that evaluate how well you're doing clinically, how well you're doing with your billing, your coding, and everything like that. And now that ACGME has really included diversity and equity in its evaluation, we need to have the same thing for faculty. We need to have the same things for the people who are responsible for training our students and our trainees. So I think that this is the time when faculty have to be accountable. That means that their deans and chairs also have to be accountable. They have to ask these questions. What are you doing to promote this? What are you doing to support your trainees? This needs to be a part of their evaluation that they have, I don't know, depending on your academic center, quarterly or annual. Like, this is something that you need to ask. Like, what are you doing here? When you are looking at these programs, are you asking program directors? One of my friends who is a program director, shout out to Michelle Durham, who has to answer about the diversity in her program. These are things that faculty that attendings, that leaders in these academic centers have to be accountable for. We have to include these things. So when I see these deans of diversity and inclusion being appointed, they have to make sure that that is included at all levels from top down. Hopefully I answered your question.
Thank you. And thank you so much, Dr. Stewart, for persevering, because, you know, we're really been through a lot, and I'm glad that you clarified that, because I'll say, for example, I'm at UCSF and we're now struggling through that right now, those very questions that you're asking. So I think it's really important because out of the academic centers, that's going to be where the training is going to happen. And so it's so important that we address all of those issues. See, final.
Thank you. And then I forgot to add that also these organized medical associations who support these leaders also need to have these questions for the same faculty and attendings that they have. So ask them as well, what are you doing? What are our organizations doing as well? It has to be a holistic impact.
Well, thank you. I'm going to leave. We're pretty much, our time is up, but I'm going to leave with a comment. I don't think there's necessarily an answer to it, but the last question from a Renu Kulkarni had posited whether can anybody be completely ever be free from implicit bias. I believe we can endeavor towards reducing it, but never ever be free of it. Now that's a really provocative thing to leave in at the end, but I think the effort is important, even if we never fully reach it. I don't know if Dr. Harston has any final comments in relationship, since this was our whole, you know, implicit bias was one of the goals that we were trying to share and educate everyone about tonight. So we don't want to think we're on a fool's mission. So I don't know if you have any questions. Can we rid ourselves of this?
So I think I'll have to agree with you. I don't believe that anyone can ever completely be free of implicit bias, just in the society that we've been socialized in. But do I think that you can attack it, that it can be reduced? Absolutely. Can these issues be mitigated? Can the impact be mitigated of these implicit biases by getting uncomfortable, by asking these questions, by returning to standards of care? Yes, I think so. So we can reduce implicit bias. Would anyone ever be completely free of it? I don't think so. But I'd like to end on a positive note that I say.
Well, as we always say, we don't want the perfect to be the enemy of the good.
Yeah, so I would try to be positive here and say that I believe that implicit bias can definitely be reduced. It doesn't hurt to try to eliminate it completely. No one's gonna say no to that. So that would be my answer for that question. And I thank you, Santa Clara County Medical Association, for inviting me. I am very privileged and thrilled and just excited that I was able to kick off the events. I know we have several great events coming, and I will be joining and asking my questions in the chat as well. And again, everyone is welcome to follow me on social media. I do answer and engage, unless you cuss at me and I'm blocking you. So just know that I appreciate this opportunity, and you have my slides.
Thank you so much, Dr. Harston. We have had a great evening. I just want you all to know that I appreciate all of you all's participation. I want you all to know that there will be a survey that will be emailed to all of the participants, to them shortly, and they will receive their CME certificate upon the submission of the survey, and also a certificate of attendance. If you have any questions, issues, or email, Samira at sccma.org. She will be the one that you will find, and I trust you, she will solve any problem you have. Thank you again for the Bay Area Medical Coalition for collaborating with SCCMA. We invite you all to the second, third, and fourth session. Our second session is going to be on September the 20th, session 2, Eradicating Gender Bias in Medicine. Session 3 on September the 17th, Minorities in Medicine, a look at physician diversity. And our final session, session 4 on September 24th, will be Health Equity, Resilience, and Leadership in a Time of Crisis. Thank you again, everyone. Have a wonderful evening and hope to see you at our next session.
Thank you.
Good night.